Hello, everyone, and welcome to the Ask Nurse Linda webinar for the month of March 2025. Here we are. My, how time flies. I'm happy to have you with me today, and we have lots of things to talk about. I'll describe myself. I'm called Nurse Linda. I am a nurse, and I have lightly pigmented skin. I have brown hair. With a little bit of silver streaks in it, but doesn't show up much on camera, as I always say, so I'm always happy about that. And I have on a red sweater, and I have on pink rimmed glasses that are kind of very light pink, so it's not too bold. But anyway, so here I am. So I wanted to open a little bit with some things that, as rehab nurses, things that we really key into. And I know that these are the issues that most patients have and most people out in the community have. So I wanted to talk about the big three. Of course, the number one is we always want to make sure that people are breathing and breathing well. So we always do that little quick assessment. Every time we see you, we're checking that. And but the big three that people have the most issues with when they have paralysis are the bladder issues, bowel issues, and skin issues. So I just want to talk very, very briefly. We do have those information booklets that are written for people who are well, they're for anybody who has any kind of paralysis, either from neurological disease, from stroke, from head injury, from spinal cord injury. So the treatment of paralysis is pretty even across the board what needs to be done. So it works really for anybody, but we do have our educational booklets on bowel, bladder, and skin care, which are written for the consumers. So they're very easy to read. You can get them in multiple languages. Of course, there is no cost to you. You can get them online, or you can call the Reeve Foundation, and they will send you some if you want a paper copy. So we do have somebody who's already in the question box. When we'll be able to ask questions, you can ask them right now. You can start typing those in now. I have some pre-questions, but I just wanted to talk a little bit about bowel, bladder, and skin because I know there's some questions about those this month in particular. And so I wanted to start with bladder because, well, bladder and bowel, a lot of people will have questions about and misconceptions about bowel and bladder care and skin care as well. But bowel and bladder, when you have paralysis, is very common to have what's called neurogenic bowel or neurogenic bladder. And it happens with spinal cord injury, it happens with neurological injury. It happens in 60% of the people who have head injury or stroke. So that's more than half of the people. And the problem is it's an issue with nerve communication. The message is not transmitted back and forth from the brain to the bladder and bowel or from the bladder and bowel to the brain. And so a lot of people, well, most people have never ever heard of neurogenic bowel and bladder before until they have paralysis. And then it's like, well, wait a minute, what are you even talking about? Because it's when you get outside our world, a lot of people don't deal with this. So a lot of people have misconceptions, and maybe they have a bladder issue, and maybe bladder automatically comes out, and they think, oh, I've got an incontinence problem. But it's a problem because of the way the bladder's working. It's not getting these messages. So you can't treat it with overactive bladder medication unless you're fortunate enough to have neurogenic bladder and an overactive bladder. So, there's all these crossovers, but the main problem is neurogenic bladder and bowel, which is this miscommunication of the nerves. So sometimes people, and I know there's a question today about how can I tell if I have a urinary tract infection? When you have paralysis, sometimes you don't have the same sensations. And so all the symptoms of urinary tract infection usually are things like frequency. So you have to, toilet a lot to empty your bladder. It feels like you have to go all the time. And so if you have paralysis, you might not have that sensation. Sometimes people have pain in their bladder, and if you have paralysis, you might not feel that uh, pain. You might sense that you have a fever because that is also one. Sometimes people get flushing on their cheeks from fever and they'll realize that they have fever issues. Sometimes people will have sweating, usually above the level of the injury. People who sweat generally don't sweat below the level of injury. Aha, but we have a question about that we'll be answering later in the show. And so there are other ways that you might recognize a bladder infection. So fever, sweating. Sometimes people have what's called referred pain, and you probably know about referred pain from people who have heart attacks, and suddenly they don't feel pain in their chest, but they'll feel pain down their left arm, or they'll feel pain in their jaw, and particularly on the left side. Sometimes it's shoulder pain. If you have a urinary tract infection, you might get some of those sensations, this referred pain phenomenon in your shoulders, if you have sensation in your shoulders, or you might feel it on either side of your jaw. So that's one of the things to think about. Sometimes people have, and this one is so arbitrary, but sometimes people think, I just don't feel right. There's something wrong, and I just don't feel right. And how do you describe what that is? But it's just you feel a little off kilter, you feel maybe a little foggy in the head, you're maybe, just having trouble concentrating and stuff. You're just not feeling right. That can be a urinary tract infection as well. And so I know the person who was asking in was asking about how can you tell, without lab tests, and those are basically the main signs. There's more in our urinary tract, the bladder booklet that will give you more information, but those are basically an overview of what happens. Now, sometimes people see, and I know one of the questions was, if I have elevated white blood cells, then I know I have a urinary tract infection. Maybe yes and maybe no. It could be from something else. So you really need to have that urinalysis to tell us that if you have a urinary tract infection. Sometimes there might be blood in the urine. That might be a clue. There are people who say when they get sediment in their urine that they know that they have a urinary tract infection, and for whatever reason that works for them. There's no like scientific research that says, oh, if you have sediment in your urine, that kind of white, um, looks like just some white powder in your urine. There are sometimes that people will say, well, now I know I have one, but there are many people who have sediment in their urine for other reasons, and they do not have a urinary tract infection. So you really have to get to know your body and know what those signs are, and that's very important. You have to catheterize or have some kind of containment for your urine. So maybe you have an indwelling catheter, maybe a suprapubic, maybe you've had the mitral FANOC procedure. So there are different things that you have to do to manage your bladder, because if you're just waiting for urine to leak out, number one, that's you're going to be wet all the time and you're going to have skincare issues. And that urine is collecting in there, and that's going to lead to more infections. So, oh, maybe if you're a man, you might be wearing an external catheter as a collection device also. So those are things that you need to look out for. So you really need to take control of your bladders to make sure that it's emptied at the appropriate times. And so that could be intermittent cath. It could be, any of a variety of the techniques that I've already mentioned. Now, some people say, well, the urine's leaking out, so I'll just go in a undergarment brief kind of thing, but it might not be completely emptying. That's going to lead to more urinary tract infections, and also if you don't manage your bladder and your bladder gets too full, and if your sphincter, your internal sphincter, there's two sphincters to the bladder. Males can see the opening for their external sphincter. Women can, well, it's up inside the penis, but women can see the opening. If they can visualize the area, they can see the opening, and there's a sphincter there where the catheter goes in. That's the external sphincter. It's the internal sphincter that gives us the problems. And sometimes it can be just open and urine just flows right out. Sometimes it can be too tight. It can change during your spinal cord injury or during your time of paralysis. It can change and it can close off and seal off, which means that urine won't come out of your bladder. It won't overflow. And so where's it going to go? It's going to go back in the two ureters and go back up into your kidneys with kidney damage. And that is big trouble. So we don't want that to happen. So you really need to pay attention and follow your bladder program to manage your bladder. You, as the individual, need to know what your bladder program is. If you can do it yourself, fine. If you have someone else do it for you, be sure that you know when it's time to empty your bladder. Be sure you know how the procedure's done because you might have somebody come in and maybe they've never done this kind of thing before and they don't know, or they don't know how critical it is to stay to your fluid intake schedule and your catheterization schedule. So you as the individual have to know how to control your body. The other thing is neurogenic bowel, which is an even bigger issue. Somehow people can be like, okay, I understand neurogenic bladder, but people don't get neurogenic bowel. It's a problem with the nerves. It is not because you have a constipation problem. So sometimes people will see that their stool is kind of dry because with neurogenic bowel, it's not traveling through the bowel quickly enough. And so the whole time the stool's in the bowel is constantly taking water out to form the stool. It goes at the top of the bowel, it goes in as a liquid, it comes out as as more of a soft solid in stool formation. So as long as stool's in there, it's more and more fluids being withdrawn. So stool can become constipated with a neurogenic bowel, and you might have to treat that neurogenic bowel. But in reality, the problem is neurogenic bowel, and you need to do a bowel program. Now, as I like to tell people, no one has ever heard of this before. I mean, really, it comes as quite a shock. And no one has ever said to me, oh, good, I get to do a bowel program. I can hardly wait. Everybody's like, wait a minute, I have to do what? And so it's an adjustment to get used to it. But it you do get adjusted to it. And you know, once you get realize, well, okay, this is the way it's going to work, this is what I'm going to do, and move forward with it, it becomes more second nature to you. But you need to also know and look at your own stool. If somebody else is taking it to the uh, toilet for you or disposing of your stool, you need to know what that's like. And so you need to really carefully manage that. Now, while you're learning to manage it, guess what? There's an app for that. There's an app for all of this stuff. Came out of the irritable bowel syndrome, but it's a good app to have on your phone. It's free. You can download it for free. And it's a good app to have on your phone so you can trail across. So if you go to the doctor with a bowel program, or if you go with a bladder program, issue and the doctor says, when did this start? And you're like, did it start last Tuesday or did it start last Sunday? I'm not quite sure. You have it all chronicled there. Now, I'm not one for writing a lot of things down, routine things, but it's something you might want to do while you're learning to train your bowel, especially because then you can follow along. You can use what's called the Bristol scale, which is a 7-point scale, which shows you a picture of what your stool should look like, and it gives a description. And there's, even if you go online and look up Bristol scale, and then look up where they have diagrams and stuff like that, you'll see all kinds of this Bristol scale chart, and they'll show you what it looks like using different forms of candy bars. Kind of gross, but it does look like this is what that stool looks like. So it's kind of a new kind of thing. Um, so anyway, it's something that's very helpful. And then also there's the issues with skin. And I know that there's some questions about skin that we have today, but with paralysis, because of the lack of sensation and because you're not moving your body, look at me, I'm moving a little bit here and there and I'm twisting around. And that's what people who have sensation, we move and we shift our weight without realizing that we've done that. Very interesting kind of thing. It's just kind of a second nature kind of thing. But when you're not feeling and getting that feedback that it's time to move, oh, wait a minute, I've been leaning on this elbow too long, or I've been resting my arm here, and well, that's starting to bother me. You kind of get these sensations that you don't really interpret. It doesn't think, oh, this is really bothering me. Well, I better put my hand down then. You just do it because it's just becomes a natural part of life. And so people are more prone to pressure injuries, which usually happens from a bone inside the body that has a bony, what we call a bony prominence. And so if you think about the bottom of your tailbone, it kind of comes down, it looks like the very last part of the spinal bone part looks like a shield. And at the bottom of that shield, down here at the bottom, is like a pointy bone. And so that's why so many people get sacral pressure injuries because that bone is pressing on that. You have to relieve the pressure. So you really need to do those pressure release activities to keep that from happening. Now, younger people who have paralysis and they, oh, nothing's ever happened to me, so I don't really need to do that. Well, that's good, but get in the habit of it because your body will age and you will get a pressure injury unless you're doing it. Now, some people are just not as lucky to have that healthy kind of internal condition in their body. And I think it comes more from the autonomic nervous system. But sometimes people who are younger do get pressure injuries from sitting too long, or people will say, well, I have a pressure dispersing cushion. That's what we call them in healthcare. And people will say, oh, I have one of these. And so they say, well, that's fine. I don't really need uh, to do anything. But if you don't have that cushion, you're going to have more pressure. And also, you still need to do the exercises because there's not a cushion in the world that can keep you from getting a pressure injury. They can reduce your risk, but they cannot 100% keep you from getting it. If you get a pressure injury, then that area that of skin that heals over the top eventually um, is scar-like. It does not have elasticity like skin. I can move my wrist like this because my skin stretches over there, or if I move my wrist like this, it kind of wads up here. So you don't really have that elasticity um, after a pressure injury heals. It's basically a scar. And so you're more subjective once you've had one to have more. Now, the best treatment for a pressure injury is to stay off of it. And there's a lot of different advice that's given out in the healthcare world of, well, we put this dressing over the top and it has less than an eighth of an inch padding on it, so you'll be okay. You can sit on this because there's padding there. That's not going to have it. So you hear people, I've had this pressure injury for months. I've had this for even years, this pressure injury, and it just won't heal. Well, do you stay off of it? No, I don't. So it's better to stay off of it when you first see that pigment change in lightly pigmented people is kind of a pinkish area, and you want to wait until that's resolved until you get back in that position again. And then you want to check it frequently because you don't want to say, oh, it's gone now. So I'll sit back there for another 6 hours on it because it's going to come right back. That's when you see that lightly pigmented, or in people who have darkly pigmented skin, you're going to see more of a purplish sort of area. Once you have that, you want to look at that very frequently because that's the capillaries breaking down underneath the outer layer of your skin. That's what you're seeing happening. It's going on inside of your body. So that bony prominence is sticking on the skin and it's pressing on the skin, and then you're going to get that spot on the external skin. So there's already a lot of injury that's gone on, even if you can get that pressure area, just that non-broken skin to resolve. So take care of it early because if it gets so bad that you have to have surgery, you might be in bed for like 9 months is not unusual. So I know that's shocking. So you want to take care of those pressure injuries as soon as possible. Now, I get a lot of questions about what kind of cushion should I be sitting on, or what kind of bed surface should I have, and what's the best one to buy. And my answer is always the same, and it's a horrible answer, but it's the truth. And that is the best pressure reducing equipment for you is the one that's right for your body. So it depends on the size of your body. So maybe you're a person who has a little extra padding through fat, and people will say, oh, that's okay because I've got fat, that's my cushion. Fat collapses and causes more pressure. Or you might be a very thin person and you don't have much muscle tissue. Maybe your muscles have atrophied a bit due to lack of movement, and so there's no muscle. The muscle really helps cushion over those bony prominences. So if your muscles waste away, you don't have as much muscle cushion. So you need to keep moving. There's all kinds of equipment. There's some that are foam pieces of equipment. Now, people will say, oh, I got a pillow, or I went to the craft store and got some foam because it's so much cheaper. That is made differently. That collapses and causes more pressure. This is a time where you have to pay the money to get hospital grade equipment. It has to be because the cells in that equipment, the way they make the foam cells, are differently and they cushion and they don't collapse, causing more pressure. So you have to be very careful with that. Some are air cushions, and those are nice. People like those. Some people need that, but again, it depends on your body habitus and what you're like, what you're doing, how much movement you have. Some people they do their religiously, they do their range of motion exercises to keep their body below the level of injury healthy. And so that keeps the muscles and the nerves kind of tuned up a bit. Some people give that up right away, and that's unfortunate because that's about one of the best things you can do for your body because your body is craving movement, whether you know it or not. Your body wants to move. So, and then there's airflow mattresses. Again, it all goes into different prices. A lot of it goes on how much movement do you have? Can you move yourself? Do you do your pressure dispersing exercise movements? Did you ever have a pressure injury? It all depends on you. Now, the way you can pick out the mattress that's the best for you is you can go to your therapist and your doctor can order pressure mapping. So they might even come to your home and do it on your bed to see, what exactly that you need. So they might be a home visit, or you might go to a facility where they a mat this like it's a thin piece of material that just fits over the length of the bed, and it has electrodes in it. So when you lay on the bed, there it hooks up to a computer program, and the computer program will be red where there's a lot of pressure. That will always be over a bony prominence, or it will be shades of orange, not quite so bad, but we need to do something more. If it's yellow, that's pretty good. Green, you're good to go. So those are the kinds of things that they will do. They can also measure how your wheelchair is fitting with pressure mapping. And so they will put that in your chair. If you just are using a cushion on your seat, they have a cushion size one. If you need back support or head support, they can measure you all the way up and down. Now, I was just at the Reeve Summit in Denver last month, which was fabulous, I have to say, and met a lot of people there. They had different people selling things, and there was a company there, nurse invented, nurse owned, emergency room nurse. I have to give my shout outs to my sisters there. They both happen to be females, but they're inventing a new pressure dispersing uh, cushion. Right now, it's just for the wheelchair and it's not in market yet. I need to let you know that it's not in market yet, but it's a pressure mattress, seat cushion that you sit on, and it has this wave motion. They call it wave therapeutics. So that there's channels that go like that, they look like fingers that come up. But these channels, so like the first row, if you think of my hand, I can't make my hands do it. If you do the first row, these collapse. And then as they go up, the second row collapses. And as those go up, the third row collapses and it moves. They've thought of everything. It moves from front to back. It always goes from front to back. And I was just like, well, that's so genius because if it's moving from front to back, that subtle little motion is going to hold you in position in your wheelchair better. Oh my gosh. If it moved from back to front, slowly over time, if you were in your wheelchair for a couple hours, they'd be pushing you out of your chair. So you see, they've thought of everything. It's keeping you positioned in your chair. Now, as I said, it's not out in market yet, but their plan is to have a very reasonable price. So it's some way for therapeutics, something to think about. There's a lot of cute brands out there for your bed. They're just doing wheelchair right now, but they're going to move into bed and other kinds of cushioning for you. So something to think about. Now, as I was saying earlier, I was talking about bowel and bladder. So skin, we have a lot of treatments that are coming out for skin, and we have a lot of treatments that are in the shoot ready to go. Some are already out for bowel and bladder. And so if you're thinking, oh, I'm going to have to do this for the rest of your life, well, maybe not, because as these new products come along and they're electrical stimulation products external to the body, if there's the product that is a piece of tape with electrodes. You can put it down on your lower spine, and then there's a control device, and it helps bowel, bladder, and in some cases sexual function. So that's still being worked on. If you put it up higher, so higher in your spine, you can get hand function. So there's a lot of things that are coming out. So if you're thinking, oh, I'm going to have to do this forever, you're going to have to do it for a while. But we can see on the horizon that there's a lot of things that are coming up. So I just want you to know all of that. So it's exciting times. There's a couple questions that are written in. It's about a bluge bluge It's a new antibiotic that's coming out for UTI. It's supposed to be something totally different. Do you have any advice? It's listed for women. Well, let's talk about things that are on the market for UTIs, because on my TV, I see them all the time. There's different products that are coming out. You have to be very careful about these products because some are treatments really for infections that come from irritation from sexual function. And so you really want to look at what is being treated. Antibiotics are created to treat certain bacteria. So not that's why when you go, sometimes you have a UTI, you get this antibiotic, sometimes you get that antibiotic, because when they do that urinalysis, and then if there's an infection there, then they'll do a culture, and then the culture will tell exactly what the bacteria is that's in your bladder. So you want the antibiotic that is going to treat your infection. So if you take an antibiotic that doesn't kill that bacteria, it's not going to do you any good. So you have to go through this process right now. So there's a lot of different products. If you go online, there's a lot of different products, especially for women, but make sure it's treating what you want it to treat. There are different antibiotic or different treatments, not antibiotics, but different treatments that I see online, and people will say, what about this one? Or what about that one? And the answer comes down to their treatments to prevent urinary tract infection. And they will cater to people with spinal cord injury because they see the market there. I will have just as many people tell me that's the best product I've ever taken, and I will never stop taking it. It's fabulous. And then I have just as many people who say that did not do one thing for me. So again, is that what is the bacteria that your body is having trouble correcting? Because people tend to have the same bacteria. Some people will have a different bacteria, but most people will have the same bacteria that keeps coming back. For some reason, their body cannot respond to that. Again, we learned through the COVID, it's the autonomic nervous system that's not recognizing that bacteria is there or what to do about it. So it's, always talk to your medical professional. Should I take this or not? Have the information about the particular product that you're wanting to try. Some people will get over the counter different things to try. Just talk to your healthcare professional, because you don't want to take a product that has something in it that's going to harm you as an individual, because everybody's unique and everybody's body works a little bit different. So always check those things out first. Okay. If I hear of something that's a guaranteed hit, I'll be letting you know. Okay, so as I say, I hear a lot on both sides of the table. We have somebody who's a T7 para. They're 45 years old. They're doing dig stim. They've never had any issues till the last 2 weeks. When I do the dig stim, it triggers spasms, which is one way the body tells me I'm having pain. They've had hemorrhoids for years. Could they all of a sudden be causing pain? They sure could. The spasms only happen when I do digital stim. Okay, now this is, as Nurse Linda, I see a lot of things, and digital stim is the thing that is unbelievably misunderstood. And so just to review, when you do digital stim, put on your glove, put lots of lubricant on there. People put a little drop on their glove. Oh, it'll spread down there as I begin the digital stim. No, you've got to lubricate that. It's goopy and it flies all over, but if you roll your finger in there so you're sure you've got the lubricant on there adequately, because if you don't, you're going to have hemorrhoids. Or if you're too aggressive, you're going to have hemorrhoids. So you want to be sure and lubricate that finger, and then you want to go in the internal sphincter of the bowel. The external one you can see, that's where you enter. And people will say, and you might even been taught this, you need to relax the sphincter. But there's an internal sphincter. That's the one you have to relax to have the bowel movement. So just going in around the opening, that's not going to do anything for you. So you have to go to up to the internal sphincter. Sometimes you'll be able to feel it and you'll be able to feel it relax. So that can be helpful. A lot of people can't feel it, but it's just up at your rectum, just about as far as the length of your finger. So if you have a child and you're doing dig stim with them, you usually use the little pinky finger, but you might not have to go in too far because look at the length of their finger. It might only be this long and not this long. So, but for adults, you use the finger and gently, gently, gently give a swirling motion to relax that. People want to get in and people want to get out and they whip it around. They're taught to whip it around. Do it as fast as you can. That will not only cause spasms, but that will tighten the sphincter, making the bowel program much longer. So those are just some tips that I have to say. Now, as far as the hemorrhoids go, what people will do if they're not too bad or when they first start, they'll again take that gloved finger and put them back in, push them back in the rectum, because that's rectal tissue. It's used to being warm and moist inside of your body. When it's outside of your body, it tends to dry out, and that's when you have the bleeding and all the trouble. So you would want to push those back in, and you can get some hemorrhoid reducing medications. Some Preparation H is the one that comes to mind, but there's several different brands that they all work the same to help shrink those hemorrhoids. And then when they get small enough, and if you keep them moist, like using, there's external hemorrhoid pads that have some medication in them to help shrink them. So oftentimes you can get those corrected on your own. And then again, being very gentle, lots of lubricant, and that will help and that will reduce your spasms as well. Sometimes people get spasms later in their injury that they didn't have before. So all those, it could be just a natural part of the process of what's happening, and you might need some medication to help reduce those spasms. There is solutions, ointments like Nupercanol that you can use as a lubricant, and it's a rectal anesthetic that will help if there's pain is being triggered by the hemorrhoids, that will help um, silence that pain. So that might be something to try. Talk to your healthcare professional. They might have a prescription medication that might be something better for you to use. Sometimes there's a suppository that you can put in before to make sure that that area is calm in there. So those are some of the things that you can do to help you get over this hump of getting those spasms, because that can be really annoying when it's just this one thing. So we need to treat that one thing, and those are some of the things to do that. how can I get rid of a UTI? I've had one nonstop since November, been on many antibiotics. I do have neurogenic bladder and I do not have any kind of catheter. But how can I get the bladder book? It's right there in the chat box. There's all the booklets are being posted up there, or you can just go to the Reeve Foundation and look up bladder care and all the information will come, but it's in the chat box right now today. So, um, what were we talking about? What was that last question that just got taken off? Let me go back. My mind wandered there. Um, sorry. Oh, the UTI, the chronic UTIs. There are some people that have chronic UTIs, and they're just, it seems like you get one, you take the antibiotic that treats that one, but then another one comes right in. And now, that's kind of opened the door for another bacteria to come in and take over. And that's why this, UTI, one antibiotic, UTI, another antibiotic, UTI, another antibiotic. So talk to your healthcare professional. You might be directed to a urologist. You want somebody who has experience with people with paralysis, because some people are using some of these flushes now. Flushes come and flushes go. They're in, they're out. Do it, don't do it. So it might be an opportunity to try some of these flushes. Also, be sure and look at what your intake is, not only fluid, but food. So if you drink a lot of alcohol, if you drink a lot of sports drink, if you drink a lot of sugary drinks of any kind, sodas, even if they're diet sodas, those tend to feed bacteria. So you have to be careful what you put in. Caffeine, sodas, coffee, iced tea, that all feeds bacteria. So really try just using an all water um, for your fluids for a while and see if that helps. If you're not using a catheter, as you say, and you can void, um, try drinking a little more fluid. Now, you don't want to be like, okay, I'm going to go drink a quart of fluid because that will overwhelm your heart. So, just try to drink, like, okay, if I normally have a cup of coffee size. I'm not saying you can't have coffee. You could have coffee, like one time a day or something, because caffeine is addictive and it's hard to get off of. I know I had the diet soda caffeine. It was really hard to get off, get a really bad headache. But anyway, it can be done. So gradually get off those things. And then if you're drinking, like, say, a glass, coffee cup size of fluid, try drinking a coffee cup and then just have another couple of swallows. That's all. And then the next day, have 4 swallows extra. And very slowly, maybe not even every day, maybe every other day, but very slowly just kind of increase your fluid intake. Now, talk to your doctor first because we don't want you to have cardiac problems because you're ingesting all of a sudden too much water. But just very slowly, just, have another sip now and again. And that will help. Also, look at your foods if you're eating chocolate or if you're eating sweets. Even though the solids come out in the bowel, fluid is extracted as that food goes through your body and it's feeding your cells, and then the fluid from your cells are coming out in the urine. So it gets in the urine one way or another. So just look at the things that you're putting into your body as well. Another thing is movement. And I'm a real big advocate for movement because when you're moving your legs, keeping your muscles toned, and trying to build up your muscles through your legs, that shakes your abdomen as you move your legs. People who are up walking around are shaking their bladder all the time. And so when you're moving, even if you're doing push-ups, you're shaking your bladder. If you go do your pressure releases by going from side to side, it's moving your bladder. It's also affecting the muscles in your abdomen. So you're getting a lot of benefit from a little bit of movement. Okay. Oh, now I'm on the wrong page now. So you go back to the open ones. Regarding bladder management, can you address the various prescription medications available? Yes. All these medications are for bladder problems, and they're for specific bladder problems. So some of these are for people who have trouble with their bladder contracting. Sometimes people have, they have more of a flaccid bladder and you want it to contract tighter. Sometimes people have trouble with balancing how the bladder contracts and when that internal sphincter opens and closes. So if you're having some rhythmic contractions, spasming of your bladder, but your sphincter is not opening to let that urine out, then what's going to happen? Shoots back up. So all these medications are to help control the bladder muscle itself, or to have the sphincter open and close, or for bladder irritation if you have irritable bladder that you just have a lot of frequency. So all of these medications are that. Some are used for people with paralysis. Some are formulated for people without paralysis, but they still might have that problem that they maybe need some of these medications. So you need to go to your urologist. You need to have yearly urodynamic studies. And if your urodynamic study comes out fine, then you say, great. The urologist will be able to say, you don't need to come back next year. You can come back in 2 years or whatever. You need to keep up with them because your bowel and bladder change over time, much as spasticity does. As the body ages, things happen. They happen to people without paralysis. So you need to catch them because you've got to protect your kidneys at all times. So these particular drugs, it's not like you can just go and, get these drugs. In other countries, you could just go to the pharmacy and get these drugs, but you have to take the drug that is for your problem. So you need to see your urologist to figure that out again. This new seat cushion, it's not on the market, but I want to keep an eye out for it. It's called Wave Technologies. So thank you for that. We like to support the people who support us. So keep your eyes open for that. Um, recommendation. Wait a minute. This is cut off here at the top. Let me see. What's the best way to easily and safely use the bathroom with paralysis? And they have cerebral palsy and neuromuscular disease. Do you have any recommendation for mobility aids for the bathroom? Well, some people will use a walker to go into the bathroom and then use the walker to help pull themselves up from the toilet if they have good enough leg function to do that. Now, the walker's just, out there. You can pull it over on yourself or whatever, but people with mild issues will use a walker, especially at toileting time. If you get a high rise seat, it's easier to get on and off the toilet. So those are also very handy. Now, most people will get bars around their toilet to help so they can help pull themselves up and down. And so I was at the LA Abilities Expo, and the gentleman from the Paralyzed Veterans of America who did a presentation on architecture and um, and issues with paralysis, and he was fabulous, I have to tell you. If you go to the PVA's website or you go to Amazon, you can get the book. It does cost, I think, about it's under $20, but you can get the book. But if you decide you want to get bars in your bathroom, be sure and talk to the contractor. A lot of people had commented that they couldn't get somebody to come put in bars because they didn't want the liability. You've got to attach the bar to a stud in the wall. They explain all about how to do this in the book. So if you're having trouble finding a contractor who will put bars in your bathroom, it'd be a good opportunity to get that PVA book or look up how to get that so that the bars are placed. If you just put the bar on drywall and you pull up to get off of that toilet, you're going to pull it off on yourself. You're going to fall. It's going to hit you on the head. It's going to be big trouble. So if you want to use bars, be sure and have them affixed to the foundation of the house and not just on the drywall. The other thing is, another thing is that people will sometimes use a lift. There's standing lifts. that are portable that will help you lift. Some people will use a Hoyer lift. So a standing lift is something that you can use to walk around with if you have some walking problems, and then it will lower you on the toilet. There are Hoyer lifts that can help you if you have problems standing. And then there's also these gliders that go on the ceiling that can help you move from room to room without your wheelchair. But some people will get them in the bathroom, and then you can go on the toilet, and you can move right to the shower, and it's very handy in that way. So that's kind of the hierarchy of that. I have paralysis. Okay. Um, Also, one other thing, if you have problems with your hands, which wasn't really mentioned, but if you need to do a bowel program and you're in the bathroom, something that's helpful is you can get suppository inserters, and then there's a separate thing for using the digital stimulation. Again, you want to be very cautious with these devices, but you can buy handheld devices. They have like a universal cup that fits around your hand so that you can put the suppository in and do the dig stim with the other device. Also, some people get a bidet that will help clean them up after the toileting. You still have to dry yourself. So, it kind of depends on how functional you are with that. Here's somebody with T2 and they're having a problem with medical personnel not listening. For instance, I'm having AD. They say your blood pressure is just fine, or I'm waiting for another orthopedic surgeon so I can have my shoulder surgery. Um, I'm worried that new doctor won't listen and try other things, which I've already done. Even when I give them the brochure, I got, and I hope you have one of these. If you feel like your healthcare professional is not listening to you and you know that this is what the problem is, you need to start looking for a new healthcare professional or caretaker, because if and it doesn't just mean like, oh, I didn't like what you say. Probably the first step would be to say, I don't really understand why you're telling me this. Could you explain? You telling me my blood pressure's just fine. What is my blood pressure? So if it's not my blood pressure, then what else is happening? Why am I having this headache? So be sure and talk to him. Sometimes people get so busy and so wrapped up in the moment that they think, oh, well, you know what you have, so you must know everything about this. And so be sure and ask them why. Just say, I don't understand. Could you please explain this? Because I just don't understand it. And if you're just finding not satisfaction, then you might have to think about changing to somebody else who has a better understanding. If you're going for surgery for this shoulder, you want to talk to your orthopedic surgeon and talk about preventive measures for when you're in bed, when you're in the operating room. How do you treat autonomic dysreflexia if I have it in the operating room? Talk to the head nurse on the floor where you will be. Will I be turned? Will I be catheterized? And get their assurance that this is the way it's going to be. Explain all your healthcare needs and say, I'm just concerned about what's going to happen, and I need to know. Because sometimes people go to the hospital and maybe your nurse, maybe your doctor, maybe the doctor who's covering that floor that day, maybe they've never seen a person who's had spinal cord injury or any kind of paralysis. So you need to talk to them about the importance of your catheterization schedule, the importance of your bowel program. Just because I'm in the hospital, I still need to have my bowel program, because when I go back home, I don't want to have to start all over with this. I've got my bowel regulated. I need it to be this way. And take the bowel book, take the bladder book, take the skincare book, offer them as gifts. Here I have these, I follow these procedures, offer them as gifts to these people. Hopefully they will take them with open arms, and hopefully you'll find people who will be understanding in that way. Next one is I have some swelling always in my legs and feet, but not much. It's weird that the toe on each foot next to the big toe has gotten maybe 1.5 times what causes this. Well, that's an interesting thing, because usually edema comes all at once. So like if it's in the foot, it's in the foot. So it's that kind of thing. So it's making me wonder if maybe your shoes are bothering you, or if you're wearing elastic hose, if they're too tight and somehow that's getting pinched in some way since it's in that second toe. That's kind of an odd sort of thing. If it was just in the big toe, you would have to look for gout, and it still could be gout in that second toe, which would be kind of a little bit unusual, but unusual things happen. So those are just kind of some of the things. See if during the day, if you can put your feet up at any point in time, if that helps with the swelling to see what's happening. So another thing is if you are diabetic, it might be something that's going on. Since it's on each foot, that could be some kind of metabolism problem that's happening. If it was just on one foot, I would think, well, it's probably just something rubbing, but since it's so unusual for that to happen. So it could be a variety of things. So it might be something, but I would check and see if you put your feet up during the day higher than the heart, which I don't know if you have time to lay in bed during the day, but if you can at least put them up on like a footstool, like if you're sitting up or if you're at work or something, if you can at least put them up and see if that helps some of the swelling, because then that would help determine if it was edema or if it's something else. And so then you would have more information when you talk to your doctor about this odd situation. That could be something, could be an infection, but being that it's on the same toe on both foot, that would be kind of a weird kind of thing, or it could be a fungus kind of thing that's going on. Maybe it's bumped in some way. Um, oh, you saw a podiatrist and he doesn't know. I would talk to your medical doctor. I would think it would be more of a medical problem, or check your shoes and see. Yeah, not diabetic. Check your shoes and see, or if it's elastic hose, check your shoes and see if your shoes are long enough. So some people, their second toe is longer than their big toe, and maybe your shoes aren't long enough because even though if you're not walking, um, your feet still change over time. Isn't that unfortunate? But our bodies change over time. But sometimes your feet, when you're not using them, they tend to expand. Again, not to bring up the COVID again, but during COVID, a lot of people were at home and they didn't put their shoes on. And when they went back to work, they found out that their feet had changed. And so it could be something like that. Um, oh, she wears her shoes and socks a little bigger. That's smart. Okay, so if the socks are a little bigger, are they getting clumped up down in the toes? Are they getting rolled up and that's irritating that? I don't know. I'm just uh kind of feeling around here because it's such an unusual problem. But I would check with my healthcare professional. Maybe that big toe's been broken in some way and it's having edema. So that could be a lot of different things. Um, Let's see. Oh, so here's somebody who has back surgery and it's been fused, and so they want to do bone growth. And so, what do you suggest for bone growth? Well, if it's possible, if you're allowed, and you've had surgery, so you have to get the all clear, and you have to get all clear from your doctor about if it's okay to stand, if it's okay, if you make sure you don't have any blood clots, but try standing. If you can't stand on your own, you can get a standing frame. Most insurances pay for those, and that putting that weight through the bones seems to help. Um, so that would probably be the best thing. And mostly what happens is healing. So you might want to see a bone density specialist to see if there's anything that you can do. There might be medications that you can take to help strengthen your bones. So that might be something. But if you've just had surgery, it's going to take a little bit of time. Sometimes people who have paralysis have lost some of their bone density, and it takes a little bit longer for those bones to heal. So you would want to really see a bone specialist to be sure and be sure that you're getting the right treatments for your bones. But usually activity and standing usually help, but you need to check first. You can't just go out and do these things. Um, want to talk about chronic sweats. Okay, now this is the thing that I talked about way at the beginning. I didn't know it'd be so far at the end. I thought we'd be here much sooner. But anyway, the chronic sweats, I really wanted to get to this because most people, if they have a spinal cord injury or if they have a stroke, They might sweat on one side of their body, but not on the other. They might sweat above the level of injury, but not below. Except there are some people that just have this chronic sweating and they just pour fluid out of their bodies. It just happens. So there are some treatments and medications that you can take for that. But you'll have to talk to your doctor to get the right thing that's right for you. So those are some of the things that you might want to think about because there is treatment for that. There's some medication that you can take. I know it's really hard because a lot of people they literally have to get up and change their sheets and their clothing because everything's just dripping wet and they can't, it's just this excessive sweat. Now, some people do that. Some people have it just like in the palms of their hands. And this is with or without spinal cord injury. Some people just have it in the palms of their hands or on their feet. And there's some treatments where you put your hand in this tray of fluid and there's a current that goes through it. Will not electrocute you. It's not that kind of thing, but that's a treatment that can have it. So it's an isolated area. It's treated a little differently, but I'm just assuming this is throughout the whole body. So you might want to take some medication that has that. Somebody has numb and stiff fingers and so they're want to know which nerves control these. Well, there's a variety of nerves that control those things. All the nerves in the arm and coming out of from the neck and around in the shoulder area, all those nerves and all the individual nerves. So the nerves that come out of the spinal cord are central nerves, and the nerves in your arm are peripheral nerves. And so they're trying some light therapy and they're taking some medication for neuropathy. So those numb and stiff fingers, if it's from paralysis, it could be because of the nerve. So you would want to talk to your healthcare professional because they can do electrical studies on those nerves. If it's a problem with the nerves in the arm, in the peripheral nervous system, there are treatments and some electrical treatments, some functional electrical treatments that may help, or even there's nerve grafting and there's different nerve surgeries. They can move nerves around in the peripheral nervous system. You cannot move them in the central nervous system. So you check and see if it's in your central nervous system or in your peripheral nervous system. Now, if it's in the central, then you would take things like things for neuropathic pain, our stiffness, and then be sure and do your exercises because if your fingers are stiff, but if they are movable or if you can move them, there are exercises that you can do to help stretch out those muscles and give feedback to those nerves. That very gentle exercise will help, and then that might release some of that stiffness. So there's more things that you can do there. Is there any news about fixing people with SCI? Yes, there's all this that we've been talking about that's out in the world, the electrical stimulation that's being applied externally to the back. We started out with just applying it to the legs, and it was over the skin, over the nerve on the legs, and then they moved to doing implants in the spine, which was really big surgery. It worked really well, but the surgery was so big. So then now they've moved to these patches on the outside. So see, things are constantly improving. And there was one more. I know we're running out of time. So I think we've got all the questions answered for today. I think these ones before. Oh, this is the one I was thinking of. At what time frame to just give up walking again? Okay, people have told him that they would never walk again. Okay, let me just tell you, they are wrong. They are wrong. I believe everybody will, if they wish, not everybody wishes, but if they wish, I think that we are very close to all different kinds of treatments. So, like right now, some people have learned to walk again. It's not like it was before, but again, we're making advancements. So, there's exoskeletons, which are external devices that you put your body into like a brace, and you wear a power pack on your back and they move your legs and you walk along. they're covered by Medicaid. Who knew? It's a rather new thing, but they've been covered for a while. You may or may not be eligible for that treatment. There's all this electrical stimulation that's just really going to town right now. So there's a lot of things that are out on the market. There are new drug treatments to treat nerve injuries and to help the nerves regrow. They're being studied right now. So they're not out yet, but they are being studied. And so, things are in motion. So when I went to nursing school, we were taught, don't ever tell anybody, don't let them live in that artificial world that they're going to walk again someday. In my heart and in my soul and in my brain, I myself personally believe that these things are going to happen. So if somebody is that negative and they're not that interested, you might want to try somebody else and see. Um, Okay, so we've got some thank yous on here, and there's one more question that's been asked. So I'm going to try to flip to that real quick and see if I can briefly answer that question. Um, do I know people who have paralysis due to neuromuscular disease, cerebral palsy? Do I work with people? Yes, I work with anybody who has paralysis from anything, as does the Christopher Reeve Foundation. I read that. Do I know somebody? Yes, my husband had paralysis from neuromuscular disease. And what I have discovered about people who have neuromuscular disease, they don't identify with the paralysis community. They identify with their disease. So cerebral palsy or genetic disease or um, neuromuscular disease, Parkinson's disease. My husband had neuromuscular disease from a genetic problem. And so, but these people, but you identify with the group, your diagnostic group. But what people are finding out is that where you go for issues with paralysis is to the Reeve Foundation, and we welcome everyone. And people have different issues with paralysis, but there's all kinds of information. So please welcome, and we're just so happy to have you. And on that note, I'd like to say have a great day. It's been a really good discussion today. So I thank everybody for coming, and I hope to see you again next month.